A patient with hypovolemic shock presents with a plummeting blood pressure and a racing heart rate. On the opposite end of the spectrum, a patient in severe fluid overload shows bounding pulses and systemic edema. Intravenous fluids are the most common medical intervention in hospitals, but choosing the wrong bag can rapidly push a stable patient into cellular collapse or fatal pulmonary edema. This diagram shows a blood vessel running alongside a layer of cells. The movement of fluid between these two spaces is governed by tonicity. When you administer an isotonic fluid, like normal saline or Ringer's lactate, the fluid stays exactly where you put it. It expands the vascular volume to support blood pressure without crossing the cellular membrane. Hypotonic fluids, such as 0.45% sodium chloride, behave differently. They shift fluid out of the bloodstream and drive it directly into the cells, causing them to expand. Hypertonic solutions, like 3% sodium chloride, act as a chemical sponge. They pull fluid out of the cells and draw it back into the vascular compartment, shrinking the cells in the process. Mastering these mechanisms allows a clinician to accurately interpret daily weights, intake and output charts, and urine osmolality. You have to know where the fluid is moving to restore patient homeostasis. This chart outlines the 4-2-1 rule, the standard method for calculating a patient's baseline hourly maintenance fluid requirement. You assign 4 milliliters per kilogram for the first 10 kilograms of body weight, 2 milliliters per kilogram for the next 10, and 1 milliliter per kilogram for every remaining kilogram. To administer that volume without an electronic pump, you need the manual drip rate formula. You multiply the total volume by the drop factor of your tubing, then divide that result by the time in hours multiplied by 60. Let's apply this to a standard clinical order: 1,000 milliliters of normal saline over 8 hours, using a giving set with a drop factor of 20 drops per milliliter. Plugging in 1,000 for volume, 20 for the drop factor, and 8 for the hours yields a rate of 42 drops per minute. Pause the video and calculate the rate for a new scenario: 500 milliliters over 6 hours at 20 drops per milliliter. The answer is 28 drops per minute. Electronic infusion pumps fail, and they are frequently unavailable during patient transport. Calculating manual drip rates ensures fluid therapy continues uninterrupted, regardless of equipment availability. This diagram illustrates the Parkland formula, the primary equation used to calculate massive 24-hour fluid resuscitation for severe burn patients. It multiplies 4 milliliters by the patient's weight in kilograms and their total body surface area burned. There is a strict time distribution for this fluid. Exactly 50% of the calculated total volume must be administered within the first 8 hours. This 8-hour countdown begins at the exact time the burn injury occurred, not the time of hospital admission. An accurate patient history directly dictates the speed of the infusion and determines survival. Administering high-alert electrolytes like potassium chloride too rapidly overloads the heart, leading directly to fatal cardiac arrhythmias. Potassium chloride must never be given via an IV push or an unregulated gravity line. It requires the precise mechanical regulation of an electronic pump. Excessive isotonic fluids overload the circulatory system. Fluid leaks from pulmonary capillaries, flooding alveolar air sacs. This presents with rising respiratory rates, crackles, and bounding pulses. Immediate nursing intervention dictates stopping the infusion, elevating the bed, and administering diuretics to clear excess fluid. Identifying localized IV site complications like phlebitis and infiltration during routine checks prevents these minor equipment issues from escalating into systemic circulatory crises. This infographic outlines the interconnected pillars of fluid therapy. You must understand fluid tonicity types, master calculation formulas like the 4-2-1 and Parkland, and execute the 5 pillars of monitoring: vitals, weights, intake, output, urine, and lung sounds. Vigilant monitoring and precise mathematical calculations are what separate routine procedural care from life-saving clinical intervention. For further study and practice, visit the UCMS platform.